Next, we'll have the presenter, Dr. Kavitha. She'll be presenting on analysis of congenital nasolacrimal duct obstruction as a risk factor for ametropia in children.
Good evening, judges and my dear friends. Looking at other papers, I feel now my topic goes on the basics in pediatric. It is refraction. I have no financial interest in this presentation. We know that persistent watering during the sensitive period of visual development, that is 3 to 9 months of age, which requires the presence of actually a sharply focused retinal image, may hypothetically cause blurring of vision and lead to form deprivation amblyopia. We also know that substantial emetropization occurs between 3 to 9 months of age. This actually is associated with peak symptoms of CNLDO. So the focus is usually on treating the children with CNLDO, that is for watering and discharge, and we have the tendency to miss on the refractive status of these eyes. What is there in literature? Already we know that unilateral CNLU is associated with high risk of emetropia, and a few studies have also considered all the amblyopic risk factors and their association with CNLDO. Now let's say if CNLDO is proven to cause emetropia and amblyopia, this should definitely alter our treatment protocols in a simple way, which I want to emphasize here. It needs definitely an early referral and treatment. In our study, we have considered only one of the risk factors, that is refractive error. So our aim was to analyze the refractive status in children with CNLDO and to compare the refractive status between CNLDO and the control group, and to compare the laterality of refractive error in the CNLDO group between unilateral and bilateral affection, and to compare this also with the control group. So this was a prospective cross-sectional comparative study. Duration was 15 months, age range was 6 months to 6 years, and we had two groups. That is, the first one is the CNLDO group comprising 60 children, and the control group, which was an age and sex matched one, also including 16 children. And we obtained written informed consent was obtained from parents of all the children who fulfilled the inclusion and exclusion criteria. So in CNLDO group, we include children with epiphora or discharge from birth for 9 months or 6 months respectively. That is, children who did not recover with lacrimal sac massage and or medical treatment. It was unilateral or bilateral, and who did not undergo any surgical intervention. In the control group, these were the normal children, and these were age and sex matched normals. To exclude, children with watering and punctal anomaly, preterm, low birth weight children associated with systemic and other ocular pathology were excluded. Definitely with prior history of surgery was also excluded. All these children underwent a detailed examination, and in this I want to emphasize that these children underwent a basic refraction after being used with age-appropriate cycloplegic drug. Examination of uncooperative children under oral or IV sedation during the time of probing was carried out, and refractive error was diagnosed based on American Academy guidelines. So all the data was analyzed statistically. There was no statistical significant difference in age and sex distribution in both the groups. Now 120 children were considered and 60 in each group. In the CNLDO group, we had 20 children with bilateral affection and 40 children with unilateral affection. In bilateral group, 8 children had refractive error, 2 had anisometropia, whereas in the unilateral group, 40 children, 18 had refractive error, 1 had anisometropia. In the control group, 20 children had refractive error and none had anisometropia. So coming to the highlights of our study, there was no statistically significant difference in proportion of refractive error between the two groups. We did not analyze the progression since we didn't have a follow-up study in this study. In each group, the most common type of refractive error was astigmatism, and on comparing the type of refractive error between the groups, we found that in the control group, astigmatism was more common, whereas in the CNLDO group, we found hyperopia to be more common, and we know that hyperopia is a amblyogenic factor. Anisometropia was present in 3 CNLDO children and none in the control group. So this is yet another amblyogenic factor. Unilateral CNLDO had higher refractive error as compared to bilateral group. There was a statistically significant difference in spherical power between the two groups. However, there was no significant difference in cylindrical power. So what were the distinct features of our study is that it included the control group, which was age and sex matched, and we analyzed only one amblyogenic risk factor, so there were no confounding factors. However, like any other study, we
please
did have
conclude, please,
limitation. It was a
Time.
smaller study.
Time up, please.
Okay, to conclude, we had these two factors, hyperopia and anisometropia, and all these children need to be evaluated for refractive error, and they need to be followed up yearly.
So with the unilateral CNLDO cases,
We had a higher.
Was the anisometropia, the eye affected was the same eye that had the NLDO?
Yes, sir.
What was the hypothesis with so many? Was there any underlying hypothesis which you could make? Why, or it was just an incidental
It
finding?
was just an incident because I have it's just a cross-sectional study.
But what led you to think that? Was your previous experience or in?
Yeah, many studies have shown that there is an association. So if we consider that this is, and there are also studies which say that they have not found it to be an association, refractive error and CNLDO.
When did you perform your first refraction for a unilateral CNLDO child?
Around 7th month.
So how was it done?
I use homatropin drops, usually prescribed 3 times 3 days for both the eyes, and then I do it in the OPD itself. For dilatation, I use tropicamide, and then I do the refraction, and then I take the spherical equivalent for those children.
So you are doing, that's what I wanted to know, you are doing in OPD?
OPD, these children.
Okay. And when do you
But
prescribe
little
the
older
first
child,
older child you can do in OPD, but for a 6-month-old it's
in the
difficult.
OPD, it's possible.
Yeah, it's a very difficult. She is a very skilled doctor, I should say, doing refraction for a 6-month child at OBT. Yeah, that's great. What about the first glasses you give?
First classes I follow up, ma'am, actually. If I get two readings in the same way, then I tell the parents that I want to give the glasses. But if it's really high, then I give. Otherwise, I would follow up.
And who is doing the refraction for your kids, like you, the
No,
optometrist?
optometrist, yes. We have senior optometrists who are doing only the pediatric work.
Yeah. So the most important thing is 3 consecutive readings should be taken because it's quite variable. And I don't know whether homatropin is better or atropine. I would like to get comment from, like, what do you say?
Atropine.
Atropine.
Atropine is better.
Less than 2 years, always atropine is
Atropine
better.
is better.
Cycloplegic refraction.
So
Because I'm following it up, so again I can take a decision later that if I want to really repeat with atropine.
I think on the first go only we can go with that. That was my per se, like. Maybe it varies from, like, people have stopped doing cycloplegic refraction. I'll tell you the truth. People in private practice, I have seen many of the top practitioners not doing cycloplegic, just doing a tropicamide refraction. So it's good that we pediatric people are at least doing cycloplegic, homatropin and other refractions. But what is more important is, in the first go with atropine, I think it's better.
Maybe a sequential axial length evaluation can help.
About 6 months, it's not easy.
No, I have not.
And then after 1 year with the IOL master or something, if it is possible.
1-year child getting an IOL master, I have not done. Maybe you might have done. I do IOL master for all my pediatric patients, but not for 1-year-old child.
1 year we haven't done, but we can try with a B scan first, and then when the child is cooperative, B scan also gives the axial length. So for your
A scan we can do, ma'am.
see that there is no
I do,
anisometropia before
yeah.
that. It can be an anisometropia which is present beforehand only.
A scan, yes, ma'am. A scan I won't do in OPD, ma'am. When I advise for examination under general anesthesia,
that's what
I
I'm
do the
saying.
A scan, ma'am.
See, both the things are supposed to be done under GA, that all the evaluation you do under GA. So, convincing a parent also
Yes, it's
for
very
just
difficult.
giving classes, you're going to give GA is a big task which we people face. So,
Yes,
but technically speaking, if you say per se, you have to do under GA.
Yes, ma'am. Basic refraction, I do it in OPD. And if I have any doubt, and if I am thinking of intervening with probing, then I would take that opportunity when I'm sedating the child for that. It's a dual. So I mentioned in the methodology.
Thank you.
Thank you.